All right, so good morning, everyone. My name is Mark Driscoll. I'm the program manager for the Preventative Health Program. We also have our medical director, Dr. Chris Bowling, here today as well. Um, just a few things from me, and then I'll get kicked off with the webinar. If you're looking to obtain your CME or MOC Part 2 credit, I will send an email after today's webinar with information on how to apply for that. I think the next slide has our disclosure statement. So nobody involved in the development of this webinar has any financial disclosures. And with that, I'm going to kick it off to Dr. Crimmins.
Well, thank you guys for joining the webinar today. I'm one of the endocrinologists at Cincinnati Children's Hospital. My biggest interest has been in preventing type 2 diabetes. We don't have a term like preventive endocrinologist, like preventive cardiologist, but that's sort of my thing. So I see kids with genetic obesity disorders, and then kids who have type 2. But this is sort of that middle ground in prediabetes and what you do with that. So we're going to go over why preventing type 2 diabetes is so critical, especially in kids, what the screening recommendations are for prediabetes and type 2 diabetes in youth, different definitions for prediabetes and diabetes. Those cutoffs are always hard for people to remember. And then what happens with prediabetes in kids, and how do you know who to worry about? What are the potential treatments for prediabetes that are out there? And then we're going to go over the study called Discovery that our hospital is a site for. And this is a really important study that we hope will answer some of the questions that come up around this topic. I love to get questions as I go, and Chris said he'll read some of them to me. I can't see the chat on my end, but I really encourage you guys, if you have questions as the slides come up, I'm happy to stop at any point and we can talk about it. So type 2 diabetes in children, this is really a combination of insulin resistance and then beta cell dysfunction. So those two processes are true for type 2 in kids and adults, but what we know about kids is that insulin resistance is more severe than in adults with diabetes. And the beta cell failure is more rapid than in adults. So you're not seeing these kids who sort of hang out on metformin for years. This disease can progress pretty fast. They also have earlier complications related to diabetes, both macrovascular and microvascular complications. And unfortunately, there are simulations that predict that the estimated life expectancy would be reduced by even up to 15 years in youth who develop type 2 diabetes, and we don't want that for any of our kids. Today was a study, it was really landmark in our field, but it was trying to compare metformin versus metformin and rosiglitazone and lifestyle in youth who are diagnosed with type 2 diabetes. And what this slide shows is that there were really high prevalence of complications and obesity-related comorbidities in this group. And if you forward one more there, what was the most scary was that there were 17 serious cardiovascular events in the follow-up from the study, and these were in young adults. So MIs, congestive heart failure, coronary artery disease, and even strokes that happened in these kids at very, very young ages. So the good news is again, that trial was comparing metformin, which is absolutely still the first line in kids for diabetes, but rosiglitazone, and we don't really use the TZDs anymore at all. So it used to be you had metformin, the TZDs, one of which was pulled off the market, and insulin, and that's all we really even had. And even though metformin is still the first line, now we have these GLP-1 receptor agonists that are approved in kids under 18. So the ones that are approved are daily liraglutide, which is marketed as Victoza, dulaglutide, which is weekly, which is a huge thing when that came out, and Trulicity, and then weekly exenatide called Bydureon. You don't see that one as much. It's actually been approved for a while, but it's a very thick medicine and you have to use a bigger needle, so the kids just don't tolerate it quite as well. SGLT2 inhibitors are now approved in kids. These are medicines that change the threshold at which the kidney secretes glucose. And so This is an older slide than what I gave you, but it's totally cool. It's not just Jardiance. The other one is Farxiga or whatever it is. But there's 2 different SGLT2 inhibitors approved in kids now. We do try to keep these kids off insulin or try to wean them off, but some of them have such strong beta cell failure that we have to use basal bolus therapy in the beginning, and sometimes, unfortunately, throughout the course. The bad news is all diabetes is increasing. Even type 1 is increasing slightly. But type 2 there on the right, you see that it's increasing the fastest in Blacks, Hispanic, Native Americans, but even across the board. Interestingly, non-Hispanic whites isn't significantly increasing, but definitely minorities are at risk. The overall prevalence is at the bottom there. It's very low in search. It's thought to be, if you take just obese populations as a whole, about 1% will have type 2 diabetes when you look like cross-sectionally. So type 2 is not common overall, but we do want to make sure we're catching it and treating it appropriately. So what are the recommendations to screen for prediabetes and type 2 diabetes in kids? So luckily all the big organizations align. That's always kind of nice. But you want to screen anyone, whether symptomatic or not, over the age of 10 or onset of puberty, whichever comes first, with overweight and obesity. And then one of the following known risk factors: either mom had gestational diabetes, there's family history of type 2 in either a first or second degree relative, definitely the race, ethnicity, like we talked about, is a risk factor, and that any sign of insulin resistance. Now, this includes if there's a history of SGA, because we know those small for gestational age babies have increased risk in insulin resistance. I don't know if you guys remember this from med school, that whole Barker hypothesis thing. But we don't actually recommend getting insulin levels anymore and having that be the marker that makes you included or not in the screening, but more acanthosis or some other process like dyslipidemia that would make you think insulin resistance is there. In terms of what tests to use to screen, I think all of us probably on the call use fasting glucose and A1C as your main screening measures for dysglycemia. I did want to let you guys know the Endocrine Society has really advocated to use oral glucose tolerance tests as the best test and even cost efficient. The way we do it here, I'm not sure it's that cost efficient because we put an IV in and they come in a room and we get time points all the way through. It's sort of an academic test. But you can do them in most labs where they will do the glucose, give them glucola, they go out and sit in the waiting room for 2 hours, you bring them back and just get a 2-hour mark. One of the reasons this test has been thought to be probably the best test is that studies have shown A1C can be falsely reassuring in children. And I'm going to show you some data later. Okay, I saw that question. Yeah, later that it may not even be the best test to predict who's going to progress. Yeah, I get both fasting glucose and A1C simultaneously. A lot of times you're getting fasting lipids on this group because of their screening recommendations too. So I just get it all as one panel. Like I said before, insulin is not recommended to do anymore for routine screening, and that is a change that's come out in the last few years from groups like Endocrine Society. But the reason is the assays have a lot of variability to them, and there's this natural insulin resistance that happens in puberty anyway. And so it really doesn't correlate super well with disease long term. And whether that's dysglycemia or type 2 or any other kind of obesity related comorbidity.
Nancy, there was a quick question. You do the glucose and the hemoglobin A1C both?
Yeah, sorry. Yeah, I just grab them as like a venipuncture set of labs. If you work in an FP office or have access to a point of care A1C machine, I mean, you could always, do that point of, these tests point of care. But I think, at that age, it's really important to get lipids too. So I usually just have them go to the lab and get them all together. I can tell you in our weight management clinics, we tend to do these labs much earlier than 10. And you do see things like metabolic liver disease and some dyslipidemia, earlier. And we do tend to track that. But looking at things like type 2, in a prepubertal kid, you just don't see it all that much. And that's why that was the recommendation, onset of puberty or 10. So these are definitions with these cutoffs in terms of diagnosing diabetes. So it's an A1C greater than or equal to 6.5, fasting glucose over 126 milligrams per deciliter, 2-hour on oral glucose tolerance test of over 200 or greater, and then a random with symptoms. The random is one that's always a little challenging, but if you had polyuria, polydipsia, weight loss, and you have that over 200, you can go ahead and diagnose it there. You always want to ask about medications around the time. So were they on a steroid burst for whatever? And then again, if you have no symptoms at all, the ADA is pretty clear. You want to have it on repeated measures. They don't want you to call it on one set of labs. So this is a real life case as I was making this presentation, came into my type 2 clinic. So I just wanted to go over how this could be a little challenging in kids to try to name. So this was a 15-year-old boy whose pediatrician had done routine screening labs because his BMI was high. He had no symptoms at all of diabetes. They had no concerns when they came to the visit. His fasting glucose was 126, which if you remember from the last slide is right there at that cutoff for diabetes. He did have elevated liver enzymes, which were concerning for metabolic liver disease. He had dyslipidemia, which is also concerning for insulin resistance. And his hemoglobin A1C was 6.6. So 6.5 and above is diabetes. And insulin was done, which is fine, which was high. And then he was referred to type 2 clinic. So we got him in fairly quickly for us. We got him in, yeah, okay. I see your question. Yeah, he came in 6 weeks later and his A1C was 5.6 and his fasting glucose at that visit was 97, which both are totally normal. He had worked very, very hard to change his diet. He was very scared at the possibility of this diagnosis. So I really didn't feel comfortable calling him type 2 diabetes because he had no symptoms and it wasn't on a repeated measure. I also didn't really feel comfortable calling him normal either, even though technically his A1C and fasting sugar were normal. So I said, let's just pretend you have pre-diabetes and call it that. But it can be really challenging sometimes when you get these labs in real life. So the question was, how long after steroids do you have to wait? It sort of depends on the steroid, but usually if you wait 2 weeks after, you're good. So I would make sure they hadn't been on steroids for at least 2 weeks before you're doing the labs. Unless you're screening for steroid-induced diabetes, that's a totally different thing. So if you had a child on steroids chronically because they had, I don't know, inflammatory bowel disease or some autoimmune cancer, whatever, those kids, you want to see what their glucose status is on steroids because they're going to be on long-term. That's a great question. Okay, pre-diabetes. So this is an A1C between 5.7% and 6.4%. And then pre-diabetes is really a bucket, right? So like there's 3 different ways you can get there. It's the A1C criteria or impaired fasting glucose or IFG. You'll see it abbreviated. And that's a fasting glucose between 100 and 125. Or you can have impaired glucose tolerance. And again, that's only measured through technically by diagnosis through an OGTT. And that's 140 to 199. So how common is prediabetes? For those of you who order these labs a decent amount, you already may have a sense of this. But the best data we have comes out of NHANES. So that was this big national health examination survey where it was across the country. And they did all these labs in different measures on kids. Most of the kids they screened were with A1C and fasting glucose. And it's about 1 in 5 youth between the ages of 12 to 18 met definition by one of those 2 metrics. And 1 in 4 young adults ages 19 to 34. I like that they call 34 young adult. That's kind of nice. Definitely past that cutoff. Anyway, undiagnosed diabetes was very rare though. And I want you guys to see that, like, they really only caught a couple of kids that had undiagnosed type 2 diabetes. So again, it's not super common in terms of numbers, but it's very severe and we want to, yeah. I'm going to let Chris read that question because it cut off. I wonder if I could pull the chat up. Oh, yay. Okay. So prediabetes was more common in males when they looked at this through NHANES, but females are actually more likely to get type 2 than males. So what this is a hint is that it regresses in males or maybe doesn't progress to type 2 as much as when you catch it in females. And then globally, the prevalence is thought to be around 8% for prediabetes. So got a question, when and how often do you recommend screening when patients, oh, this is a great question, on chronic neuroleptic meds like Risperdal or Abilify, so those second generation atypical antipsychotics, I would definitely treat that as a risk factor. I would screen once a year. Now, we just completed a big study here called Mobility that we're publishing data on. And we looked at the prevalence of prediabetes and diabetes in that group. It was slightly higher than kids with obesity alone, but it wasn't like, twice that. I don't want to tell you guys exact numbers, but I think it was about 20%, I think, in that group had prediabetes. But we know those drugs can cause rapid weight gain, changes in appetite. The foods the kids are drawn to when they're on those meds, it's never healthy. No one's on those meds and gets hyperphagic for like broccoli, So I do think that's a risk factor to at least screen yearly. All right, so then what they looked at in NHANES is couple of different things, like how did you meet criteria, right? So 3.4% of the kids met criteria for prediabetes by the A1C cutoffs, 15.6 met criteria by the fasting glucose, and only 1.5 had both. Now, I think if you had that 1.5, I worry the most about that group. But then what they did was distribute it by if you would have met criteria for screening or you wouldn't have. And the numbers look kind of wonky here. There was just way more that weren't eligible for screening than that were. So that's why those numbers look so high. But it turns out that A1C and fasting plasma glucose aren't the best tests in terms of matching up, like you're eligible for screening and you're the ones who have the elevation. So the sensitivity and specificity wasn't really great. There were plenty of kids who wouldn't have been eligible for screening who had markers in the prediabetes range for both of those things. They did do a subset of those kids and do OGTTs in that population, which I like. And if the child had or young adult had obesity, there was a prevalence of prediabetes of 12.3% by fasting glucose, 4.2 by A1C, and 3.6 by impaired glucose tolerance. So those last two matched up fairly well, which is good. But if you had normal weight, 8.2% had prediabetes by fasting glucose, 3.8 by A1C, and 2.8 by IGT. And that's in the I was only looking at the adolescent group, not the young adults. So that's still a significant number that have prediabetes at a normal weight. And what do you do with that? Now, you wouldn't be screening those kids anyway by the screening criteria, but you might get those for some other reason. You catch something on a renal, or I don't know, you get an A1C otherwise if you didn't have symptoms. There are physiologic differences in what those parameters are measuring. So impaired fasting glucose, what that's measuring is reduced basal insulin secretion. So that amount you need to turn the liver off to not do its thing. So this represents hepatic and renal insulin resistance. One of the big questions I always have in kids is, are they fasting, and do the parents even know? They're up playing, whatever, Call of Duty at 2 a.m. and eating chips. Were they really fasting when they came in for that lab? Impaired glucose tolerance is going to match up with A1C a little better because what it's really measuring is impaired postprandial secretion. So you eat food, you're not making enough insulin to kind of cover that after a glucose load. And that's really representing insulin resistance at the muscle level. So putting all that together, the prevalence of prediabetes in kids actually depends on the metric. So 20%, about 20% sounds kind of bad, but if you take the fasting glucose kids out, it's more like, 3 to 5%. But prediabetes also exists in normal weight individuals, and it's showing a couple of things. One, that natural insulin resistance during puberty is there, and some of those kids could be developing type 1, and I think that's where it gets really tricky. But those numbers are way, way, way greater than what you would expect for throwing even in the kids who are developing type 1 diabetes. Also, it's clear that the rates of type 2 are much, much lower than prediabetes, but the numbers are increasing and you don't want to miss it. So like, what happens with these kids? Do they just like stay prediabetes for years, or like, how are they different from adults who have this sort of marching trajectory through glucose issues? So what studies show is that prediabetes can regress in kids. So 70% of youth with prediabetes regress back to normal glucose after puberty. And again, this is this insulin resistance time. You can see changes in lipids too during puberty. The studies show a pretty wide range of change though. So that's why these numbers are kind of wonky, but it's 2 to 25% will convert to type 2. So again, you don't want to miss that. 25 to 30% will remain in prediabetes, usually in these kind of low level A1Cs of like 5.7, 5.8. And then the majority then will revert to normal glucose tolerance at the other end of growth. So how do we know? There's a lot of numbers. So how do we know which kids are going to progress or which aren't? And the answer is we don't. We actually don't know the best. And honestly, this can cost a lot of money. So if you're repeating these screenings frequently, if you refer all of them to weight management programs and tertiary care, that would cost a lot. Not saying that's bad use of money, but you really would love to focus those interventions to the ones who you know are going to dip, because you don't want those sitting at home and tipping over to diabetes and you lose them. You don't know where they are. So I wanted to talk to you guys today about the discovery study of which we are a site. So this is the whole point of this study, is trying to figure out kids who we think are the most likely to tip over. Can we figure out who they are and what are those risk factors? So this is a really big multi-center study, and these are the primary objectives of the study, are to identify the physiologic drivers and other determinants of progression to youth onset type 2. So we're trying to look at changes in how the glucose is tracked, what is the beta cell function, what changes are you seeing in insulin sensitivity, and then what are the psychosocial behavioral factors and social determinants of health that would occur during these changes, so you can try to figure out who are the second's perfect, really. Informing approaches for a precise prediction of which youth are the highest risk of developing type 2 during that period. And then we really want to try to engage local and central stakeholders, because we want these to be studies that are not just something we're going to be doing at a research level, things that pediatricians like yourselves could use, things that are tolerable to kids, to make sure that we're doing something that's going to have practical implications too. So why do they think A1C is not as good a marker for diabetes in kids and teens, especially especially as it's supposed to capture glucose tolerance over a longer time frame compared to fasting? It's an awesome question. I don't know that anybody 100% knows. Part of it is A1C is based on assuming a 3-month turnover of red blood cells. So, you have this natural apoptosis where they kind of change out. There's a theory that maybe during puberty, those red blood cells hang around longer. And so there's just more chance for glucose to stick to them, giving false elevations. It could be they just run slightly higher blood sugars due to that natural insulin resistance that sort of stack up over time. So I think we don't have an awesome marker outside just doing OGTTs on everybody. I think it's still a good marker. And I think it's way better, to your point, than fasting blood sugar in terms of predicting who's in trouble. That's a good question. So these are the sites for discovery. And one of the reasons I think it's good for this group to hear is we do have 2 big Ohio academic centers who are doing these trials. So our institution, our Amy Shaw, who's the PI, I'm co-PI on the study, and then Nationwide Children's Hospital. So we're really proud to contribute to those sites here in Ohio. So this is the study population. If you were thinking of referring someone, we're trying to get 3,600 youth, which is a bold recruitment. Ages 9 to 14. We want all genders, all race, ethnic groups, and of course we want that as distributed nicely as we can. They have to have all of these criteria. They have to be either overweight or obese, in the age range. Boys is a little older because puberty starts a little older. And then we want them either Tanner stage 2 to 4. We don't obviously want anybody on the back end of that. We're trying to get mostly 2 to 3, right? We want like 80% of them to be Tanner 2 to 3, like right in that growth spurt transition period. But we are taking some Tanner 4. Currently, as a protocol is written, if you've had menses as a girl, you can't participate, but that may change because we're having a hard time recruiting girls. The A1C is a little different criteria than what I told you for prediabetes. Remember, prediabetes is officially 5.7 to 6.4. We're using for this study 5.5 to 6.4. And then that's the kind of the target distribution. So we're trying to get most of them in that true prediabetes range of 5.7 to 6.4. So you have to meet all that. And then you need to meet at least one more criteria. So this looks really similar to like who we're screening, but it's family history of type 2, personal exposure to maternal diabetes. So like in your pregnancy, where's some of those right now? A1C over 6. So even if you don't have the other things, but you have a higher level A1C, those kids we want to capture. If you're severely obese, so we're using BMI over 99th percentile. I know that's not technically the criteria, or personal history of IUGR, SGA, or low birth weight. Exclusion criteria, they can't be on any meds that would affect glucose tolerance. So obviously steroids would be the biggest one. We really don't want the kids with monogenic obesity, although I think that group is really important to look at. But if you guys are rhythm panel people, if you have VUSs and some of those genes, that doesn't count. You have to meet absolute clinical criteria for a syndrome or monogenic obesity, like MC4R receptor mutated kids. You can't have been already diagnosed with diabetes and then regress. That's a no-no. And you can't have been on insulin in the past. You also can't be on a GLP-1 receptor agonist for the last 6 weeks or plan to start. So if you have a family who comes in who is really motivated to try that therapy, they would be an exclusion for the study. And then no metformin for at least the last 6 weeks. So if you have a patient who's been on metformin or is on metformin and you put them on for prediabetes and they're interested in the study, you could just stop it and then send them in for the visit 6 weeks later. I'm not going to go over the whole protocol because it's pretty detailed, but these are the types of things we're looking for. So we do a pre-screening, which a parent could reach out if they're interested, or say you have seen a kid in clinic you think will qualify. Then we bring them to a screening visit and we send an A1C to the study lab and make sure they're in criteria, meet criteria. And then we get all kinds of stuff: blood, urine, stool, hemoglobin A1C, muscle strength measures, questionnaires. The study is 2 years, and we are compensating up to $875 for those 2 years. And there could be an extension that some of the kids qualify for up to another 2 years past that, so 4 years total. We do see them every 6 months, so and then annual if you get far enough out, but it is, it's not that frequent. It's just when you come, you get a lot of measures done. The questionnaires, just so you know what these patients could be getting. It does measure like depression, anxiety, quality of life sort of measures. Then we're trying to really capture like sleep and diet as best we can. Those are always fraught with challenges, but try and use measures for that. And then social determinants of health. So this is our little flyer. If you want to take a screenshot of this on your phone, or if you just Google Discovery Study, you'll get there. But they'll hook you up with the coordinators at each center if you have a family interested in this. All right, moving on to treatments for prediabetes. So this is a take home. There are no FDA approved therapies for prediabetes or progression to diabetes. And based on the data that I've shown you before, it sort of makes sense, right? But there are things you can do. So lifestyle obviously is good for everyone, right? It's not like, especially if you are screening kids who are overweight and obese. So this certainly is something you should be talking to all your patients about. When they have prediabetes, and especially if they have a family history of diabetes, I really talk about diet, not like, oh, you're overweight, this is what we need to do, but more specific to like, we don't want diabetes to progress. And to do that, we don't want to give like high glycemic index foods. And you would explain that in a very lay term, but like no juice, no sugar drinks, trying to keep the simple flour products all kids love out of the diet as much as possible. We also talk about portions and reduced snacking. And then I make a really big deal about exercise and building muscle being protective of diabetes progression, because we're really looking to improve that insulin sensitivity at the muscle. And you can make a huge change, even if the weight doesn't change, but with exercise alone. And we're using tools in our clinic like InBody, where we can show the kids that, you know, maybe your weight didn't change, but look at this, your body muscle went up and your body fat went down. And really making a point that it's body composition that improves health and not getting super focused on that weight number. So I just always say like healthy diet and exercise, that is your medicine, you know, and when you look at studies, that's what's going to keep you from progressing. Metformin, like I said before, is still the first line therapy for type 2 in both adults and kids, and people have looked at this in prediabetes. It really is safe and cheap, which is absolutely the benefits. The only reason you can't be on it is if you have significant renal dysfunction, and you would know that in a kid. That's not going to be something that's like hiding out. It really is overall weight neutral. Like people like to throw out, oh, you lose some weight on metformin. And certainly like in the mobility study, like we're really recommending it in kids on SGA therapies like Risperdal and Seroquel. But in a kid not on those therapies, you're really not probably going to see significant weight loss. But it's going to help your sugars, you know, overall. So some people have looked that if you have impaired glucose tolerance in kids, certainly metformin is shown to slow that beta cell decline in adults. In kids, in the study called RISE, it wasn't as much, but they didn't have a placebo group either. So it's hard to know. And again, we know those kids progress more rapidly through that. So the other kind of potential problem, I'm sorry, we don't have quite the right slides, but it's all good. Is you're kind of masking diabetes then. So if you have a child, you put on, you know, metformin because A1C is 5.7, and now they're at 6.3 when they come in clinic on metformin, you kind of don't know, right? If you stop that metformin, would they be in the diabetes range or not? And if they were, that would qualify you for things like GLP-1 receptor agonists or other medicines. Sometimes I will stop it. You know, if I have kids on metformin, I'll tell you which kids I tend to go to metformin on, and then really see where they are after that. Okay, we can go to the next one. Talking GLP-1 receptor agonists, you know, those are approved for for weight loss in kids with obesity under 18. And these kids, if you're screening them, a lot of them are in the category that would qualify for these medicines. To remind you, the two biggies that are approved in kids is semaglutide is Wegovy and liraglutide is Saxenda. Wegovy's diabetes approved partner, so semaglutide's diabetes approved one is Ozempic. People love to throw Ozempic around. It's like a weight loss med name, not doctors, but in sort of the lay press. But Wegovy's the FDA weight approved version of that. GLP-1 receptor agonists have been proven in both animal models, cell cultures, and adult people, to slow beta cell decline. So these are really attractive therapies to try to prevent type 2 diabetes. And again, they're very effective in treating diabetes, and multiple forms are approved for that. Overall, they are safe even in kids. There's a black box warning on there about medullary thyroid cancer, because when they did the studies in animals, mice had higher rates of medullary thyroid cancer. That actually has not been reported in people when they did the studies. But if you have MEN or multiple endocrine neoplasia syndromes in the family where they have medullary thyroid cancer, you can't use it. I can tell you, when you ask, like, is there thyroid cancer in your family? They'll say, you know, my aunt had a thyroid nodule removed, and they never know. I mean, if someone comes in, they'll just say we have MEN, or they won't. But I wouldn't worry about it if they can't talk about that term. We do see increased risk of pancreatitis, and then post-marketing, it's been found that you have an increased gallbladder risk. Now, a lot of the people who are on these medicines anyway have gallbladder risk. And again, we didn't have a placebo group like they did when they were doing the studies initially. But I do talk about the gallbladder thing with the families, and if they're having a lot of belly pain. And then with the pancreatitis, I don't use it in kids who have really high triglycerides, and I worry about that risk. And of course, the biggest problem with these medicines is cost. Anybody who's tried to write them or knows anything about them knows this. They're very, very hard to get approved because of the numbers of people who would qualify and the insurance costs involved. So I'm just going to walk you through kind of how I approach these kids, since there's not real clear-cut things to follow right now. First, I really pay attention to family history. Okay, yeah. I'll go back to these questions. Let me get through this one. Good questions, though. So is there autoimmune disease in the family? If there's like a lot of thyroid, lupus, celiac, type 1 diabetes, like those kids I'm going to keep checking, even if I'm not too worried, because I worry they could be developing type 1. And for a long time, we really didn't do islet cell antibody screening, but we're doing it a lot more now, especially if there's a family history, because there's the first prevention medicine for prediabetes called teplizumab on the market. And you basically use that in kids who are antibody positive and who have prediabetes. And fasting insulin and C-peptide can be really helpful in this situation. If you have a kid you're really not sure, just to make sure those things aren't really low and they're insulin sensitive. Type 2 diabetes is what tracks the strongest in families, though. There is a strong tracking of type 2, way more than type 1. If you have a parent with type 1 diabetes, your child overall risk is 5%. If you have type 2, I don't know the actual number, to be honest, but it's more. I'm going to say 20% or so. Sometimes I'll get the history. It's like, well, grandma has type 2 diabetes, and then they won't say anything about themselves. And I'll say, do you have diabetes? No. Then I'll say, when's the last time you've been to the doctor? Because a lot of times the parents haven't been since either a pregnancy, or if it's the dad, it could be literally 10 to 15 years since they've been to a doctor. So they themselves have not been screened. I do look at other labs to kind of give me a hint one way or the other. So metabolic liver disease, there's a paper that came out in pediatrics that I was on a couple of years ago, but it showed that the prevalence of type 2 diabetes and metabolic liver disease that was biopsy proven was actually 6.5%, which is a lot more. Remember, in like just obesity alone, it's about 1%. So I do worry a little bit more about those kids that have metabolic liver disease too. Dyslipidemia, that partnership isn't there in quite the same way, but I do sort of use it as kids that I worry about if they have multiple comorbidities related to insulin resistance. Okay, comments on off-label use of oral GLP-1 Rybelsus. Yeah, so Rybelsus is approved for, so what Rybelsus is oral semaglutide. And that is approved in pediatric patients for type 2 diabetes. Rybelsus doesn't have a weight indication, and the main reason that's true is because the weight loss effect of oral semaglutide doesn't match the injectable form. So the company was never going to go for that. Like, they can make plenty of money off the injectable. It's a safe medicine. I don't have any problem if you can get it approved trying to use it, but the weight loss effect just isn't nearly as much in the oral form. It's actually pretty good for diabetes though. And then any increased risk of clotting developed a P and Ozempic, and it was a cause. I have not seen that anywhere officially. I don't know why that would be labeled the cause, to be honest. I do think some people don't eat and drink as much just because the stomach isn't, isn't able to tolerate big volumes on these medicines. And these kids, these kids and adults are overweight and have other risks, but I haven't seen anything that physiologically would tie those two things together. I also have sort of an approach by the numbers is what I call it. So like, again, if it's impaired fasting glucose and the other measures are normal, I'm not saying never check them again, but I might go a whole year if if the family's not really interested in getting intense lifestyle education, I might go, a year or two before I check that again. If the family history is not there. There is some evidence that there's less regression in normal sugars if the A1C is over 6. So one of these studies showed that if you were in that 5.7 to 5.9 range, 42% regressed versus 30% if over 6. And that was statistically different. So 6 to me, it kind of fits with my gut feel if those are the kids I'm more worried about. Again, impaired glucose tolerance is probably the most worrisome. We just don't do formal oral glucose tolerance tests too much. I have been known to do an unofficial oral glucose tolerance test where I was telling them to go home and just eat, like have a field day, man, like pancake syrup, whatever short acting carb is your favorite, and then have them go to the lab 2 hours later just to try to get a sense of what that runs. I don't do it very often though, to be honest. And then some people are really studying continuous glucose monitoring. So these are tools we didn't have for a long time either. They're not that expensive to put. In fact, now they have this new sensor from Dexcom that's specifically marketed to people who aren't on insulin and have prediabetes. It's called Stello that you just get over the counter. But could we learn something about the patterns of glucose after eating and have someone wear a device like that for like 2 weeks, every other month and track them that way? So people are studying this right now, but right now we don't have great ways to correlate the two. Oh, Chris, you want to say your comment?
Oh yeah, I just this morning was reading about Lily's thing. You mentioned about like how Rybelsus is not effective for weight loss. Apparently, Lilly has an oral GLP-1 that they're talking about just this morning that has promising oral GLP-1 results. Just an aside.
Yeah. No, I think in kids, oral always sounds way better than injections.
Yeah.
The kids actually tolerate the GLP-1 receptor agonist injections really, really well. They use, other than that Biduron one I was telling you guys about, for type 2, the needles are really tiny, like we use an insulin injection, so they're not painful. But kids really have a mental leap to get over. They're used to getting vaccines, and blood draws, and those are very anxiety provoking. So I think it's a good question on the orals. A lot of people want that. Yeah, Lily's, so they also, Lilly now has this, what we call dual incretin. So it's a GLP-1 receptor agonist, but it's also a GIP-1, GLP-1 receptor agonist and GIP. agonists combined, and that's, if you guys know, Mounjaro is how it's marketed for diabetes, and Zepbound for obesity. Those are both currently approved 18 and up. But I know they're trying to work on getting Zepbound approved. I mean, if I gave this talk every year, I'd probably be a little different on what therapies we could talk about. There's a lot in the pipeline, but they even have a triagonist in the pipe too, that's a glucagon receptor, and the weight loss on that medicine when they did the phase 2 trials were just, I mean, there's just so much coming, you guys, and I think it's coming so fast that everybody sort of feels that pressure of like, how safe are these meds? How long are these kids expected to, be on them? So it is kind of a crazy time in terms of being a doctor who specializes in this. So I do like to evaluate for lifestyle readiness, and 100% Chris Bowling and group wrote the best recommendations for obesity. Like, this is a shared decision-making process, like assigning diets and exercise never works well. Tell the residents all the time, no family was ever given a handout and they were like, oh my God, I totally get it now. I know what I need to do. Like, it's something that you really have to work to understand what the barriers in the family are, what the preferences of the child are, and because you really want this to be a long-term healthy, change. And if you assign them something that doesn't fit, it's just not going to work. The times I use metformin, or if I have a family that's like super high risk, so like lots of people in the family have type 2 diabetes, and to them, I've seen this where it's like the kid's just not really interested. A lot of times it's a child who's never been drawn to sports or who really likes video games or their phone. I get nervous. I really get nervous about those kids. So I'm always trying to get them lifestyle plugged in either way, but sometimes I will start metformin on those kids. So like, I can't give you the exact, but A1C 6.2, mom and grandma have diabetes, the weight's really high. And I'm just having a hard time getting to engage. That's the one kind of kid where I think it's probably worth putting metformin on and having a talk about how that child's really high risk. Then I'm a fan of using GLP-1 receptor agonists if you can get them on kids who have really worked hard on lifestyle and their weight has stalled or their glucoses are still not improving with the weight loss that they're having. Those are kids that I think really should have a trial of these medications. I do have families who come in and that's their ask. I've never met them before. And they're like, I want this medicine. I've gotten this medicine. I'm very successful. I can't speak for everybody in the country, but those medicines are supposed to be given on a background of a trial of lifestyle modification and a real detailed plan. Kentucky Medicaid actually just came up with something that they are going to start approving these medicines, but they are making you spell out, you have to start it. They only give it for 2 months. You have to submit your entire lifestyle plan. And I really think that's how the insurances are probably going to go, although I don't 100% know. It's not like they just don't know who to say yes to, and I think that part is really important. So the future goals in this area is really, again, just determining who is the kid who's really at the most risk for developing diabetes, to put those resources in the best places, and really use targeted interventions for those kids, and maybe, again, advocating for something like a GLP-1. So what we could say, this kid's high risk for type 2 diabetes, we needed the GLP-1 receptor agonist or the new oral thing for Lily, whatever it is. And not that there aren't other reasons you want to focus on weight loss for kids in other models. That's absolutely not what I'm saying, but this could be, one of those criteria that helps focus the resources in the right place, in addition to maybe getting the cost of the drugs down, which, we all agree to that, right? But okay. So that is all I had. I would love, great question. I would love to entertain any questions. I love this topic. So Elizabeth is asking, do you think the price of GLP-1s will go down now that so many are on the market? I'm going to go with no. I think that's not what's going to bring the price down. It hasn't so far. Victoza was the first medicine approved in this this class other than Bietta, which was, nobody uses that. It was like forever ago. Victoza just came off patent in the last year. And I was really interested to see what the cost would be of generic Victoza, because to me, that was that first little glimpse, even though Victoza is a diabetes approved med, it was the first little glimpse of getting one of these medicines off patent, right? And the cost, that the cheapest I found it was like $350 to $400 a month still. Now it's better than $1,200, but that is absolutely cost prohibitive, you know, to the vast majority of families that we're going to care for. And one of the things that makes me sad is I do think there's an economic disparity where, you know, the kids with certain social determinants of health are absolutely at risk, but they're not the ones who can afford these meds. And it makes me sad. I think there has to be, I don't want to talk politics, there has to be different ways to control cost. These drugs are all cheaper in Europe. Like if you guys ever want to head over to like, I'm not telling you to do that, but like they're like $200 or less in other parts of the country or world. Thank you, Natalie. Shout out to my fellows who are on the call.
And I'll just hop in because I saw a question about the recording. So we do record all of the webinars and then post them on our preventative health webpage. So I will send that link when I send my follow-up email. And if there's other questions, feel free to put them in the chat or even unmute and ask questions. We have a couple minutes left.
I just wanted to thank you, Nancy. This was an awesome talk. I knew people would love this one when we were kind of discussing what to bring up. So I just am very grateful for you speaking with us about this today. It's a great one.
Thanks, Chris. Appreciate the invite. I get a lot of questions about prediabetes. We actually have started a prediabetes clinic at Cincinnati Children's because we were getting so many referrals and we kind of didn't know where to put them, honestly, you know? And so they were coming to endocrine clinics, but we didn't have an exercise physiologist there. We didn't have a dietitian there. And so we've actually made clinics to kind of assess lifestyle, and kind of get treatment plans going. Now we may refer them back to HealthWorks or our weight management program. But I think the pediatricians have recognized that there's high numbers of us and just need help on how to do it. But I also want to empower everybody, knowing that it regresses. It's okay to keep these kids who you don't have, you know, a gut feel might be at the highest risk. It's okay to keep them in your clinic and follow them over time. You guys are absolutely 100% qualified to, you know, to do that. As long as you know that family will come back and you guys have a good relationship.
All right. If there are no other questions, I'll say once again a big thank you to Dr. Cribbins. I will send out a follow-up email. A few people have asked now, so that will have a link to where you can access the video. Also, I know we had a little bit of some of the slides needed updated. We had some confusion with slides today, so I'll make sure the updated slides are posted on our website as well. And then that will contain information for how to apply for CME or MOC Part 2 credit. So thank you everyone for attending today, and thank you again, Dr. Crimmins.
Thanks, guys.
Bye.